Hello, everybody. I am so thrilled to have this incredible group of providers here together. This is going to be a really wonderful night of being able to answer a lot of questions, talk about the trifecta, talk about endometriosis and this overlap. And first, I know everyone's probably in a little different view in their box, so I'm just going to call on you guys as popcorn just to do a brief introduction, where these viewers can find you, where they can find more information for phone consults, information about your practice, and we'll start there as people are kind of logging on. Dr. Ivanina, you are first in my box, if that's okay.
Sure. Happy to kick off this event. Thank you so much for having me. I'm really looking forward to listening to all of the insight everyone has, as I love everyone on this panel and they're very brilliant in this topic. So I'm looking forward. Hi everyone. My name is Dr. Elena Ivanina. I am a integrative board certified gastroenterologist, and you can find me at gutlove.com.
Dr. Cutchins.
Hi, it's so great to be here. Thanks so much for having me. I'm Alexis Cutchins. I'm a cardiologist. I just opened up a practice in New York City as of December, and I specialize in taking care of patients with POTS, mast activation syndrome, EDS, all the things that go along with it. So you can find me at cutchinscvm.com on my website, or on Instagram at Dr. Cutchins.
Amazing. Erica, who is part of our wonderful co-host team.
Hi, everyone. My name is Erica Mikic. I'm one of the owners of Solstice Physiotherapy. You can find us at www.solsticept.com. Our handle on Instagram, I think, is at Solstice Physio. It's a little different. Kara's here with me, and we're so happy to be with everyone here today, and we're pelvic floor PTs.
And Kara, I know it gave me an error with your video, but if you want to pop in at any time, feel free. And if not, just you can send me a message on the side. Dr. Brandon.
All right. Hey, everybody. Thanks so much for having me. I'm also very thrilled to see everybody. And Dr. Cutchins, I actually have a patient I need to refer to you tonight. But I'm a board certified psychiatrist for general psychiatry and medically complex psychiatry as well. So I do a lot of integrative and functional work. I specialize in gut psychiatry, I like to call it. And you can find me at wholebodypsych.com and at Claire Brandon MD on Instagram.
Amazing. Thank you. Dr. Cates.
So I'm Kathy Cates. Thank you so much for having me. I'm a board certified nurse practitioner, and my specialty is really to care for the vulvovaginal tissue of patients that are in this Venn diagram of all of the things that we all on this call take care of. And then, so I really specialize in pelvic, sexual, and hormone health, and particularly the role of testosterone in supporting our patients with EDS, mast cell, POTS, pelvic, all of the things, the Venn diagram. And I'm thrilled to be here. You can find me at pelvichealthsupport.com and at pelvic floor NP.
Perfect. Ariel.
Hi, I'm Ariel Katz. I am a licensed mental health counselor, and I work at Women's CBT with Kelsey. You can find us over at womenscbt.com, and I specialized in working with women who are facing mental health challenges alongside living with chronic illness.
Awesome. Dr. Chu.
Hi, Kelsey. Thank you for having me. I'm excited. I know some of the faces here, and I think I need to know some of the other faces here as well. I am a board-certified GYN surgeon with a focus on endometriosis. I just moved over to SE Care about 6 months ago. and my primary office is near Grand Central.
Amazing. Thank you. And Charlotte, if you are able to join via video, you're welcome to introduce. If not, I can do a little intro.
Hi, Kelsey. Can you see me?
Hi. Yes. Perfect.
Thanks for having me. I'm a board-certified family nurse practitioner. I work at the Centers for Vulvovaginal Disorders in New York with Dr. Andrew Goldstein. We specialize in treating all causes of vulvar pain, musculoskeletal, hormonal, neuroproliferative, inflammatory, and our website is vulvodynia.com to find more.
Thank you so much. Okay, I think Dr. Sieferman may be joining us a little bit later, but for now, I'll do an intro. I don't think I said my name. I'm Kelsey Bates. I'm work with Ariel. We work at New York Women's CBT, and we had such a fun time co-hosting with Erica and Kara, an endo-specific panel last year that we decided, okay, let's do something for the EDS Awareness Month. And we are understanding more and more and more this overlap of the, issues of the trifecta of MCAS, dysautonomia, POTS, and EDS, or hypermobility spectrum disorder, and our endo population, or even pelvic pain, vulvar conditions. There's so much research coming out that as mental health therapists, we are seeing, but we cannot speak to the physical medical pieces. That's where all of our incredible panelists come in. So we are going to dive right in and start, if it's okay, with Dr. Cutchins. Dr. Cutchins, she is an expert cardiologist, as she said, specializing in treating this trifecta. I wonder if you could give us, and if there are patients here, there are providers here, if there's anyone, a patient who's dipping their toe and trying to figure out what's happening, or a provider who's maybe learning more, could you give us a brief overview of what this trifecta is and what it means?
Yeah, sure. Happy to. I feel like I say this multiple times a day, every day in my office, so I'll give it a whirl. But, I primarily see patients with POTS. Patients come to see me because they have dizziness, orthostatic intolerance. And what I've found, in my practice is that most of these patients also have some component of hypermobility spectrum disorder, or EDS. And that can also be a non-hypermobile connective tissue abnormality. So it's important to recognize that there are other things out there that may not be qualified as hypermobile, like lipedema or other underlying connective tissue problems. So most of my patients have that. And then there's this overlap with mast cell activation syndrome, which I think is primarily driven by the disordered collagen that's in the cells of patients with connective tissue disorder and hypermobility spectrum disorder. So when the collagen's not lining up right in the cells, it causes tissues to be more flexible, stretchy, and elastic, but it also allows cells to be a little less stable. And that's where the mast cell dysfunction comes in, and the mast cells get a little bit twitchy and a little bit more irritated in this population of patients because they're not structured quite as well. And the other thing that occurs is that the connective tissue allows sort of this window into spaces where the mast cells exist that maybe shouldn't necessarily be there. And so they get more activated from that standpoint too. So there's this big overlap that when mast cells degranulate, it causes tachycardia and vasodilation and orthostatic intolerance. When you have stretchy tissues, you can have elastic or stretching veins that can cause more blood pooling, that can cause more POTS symptoms as well. So the three are very closely connected.
And you have kind of already touched on why they might travel together. Is there, and I guess what I saw was in the last couple of years, this really started being spoken about more. Is there anything that you feel like started putting things together of why these things travel together, even alongside endometriosis or pelvic pain?
Yeah, so I mean, some people would say that the trifecta is sort of a narrow term, and we should be calling it a pentad or a septad because there's so many other things that kind of go along with these patients. And for me, I think that the most the kind of overarching theme or the umbrella that encompasses all of these different disorders is that underlying connective tissue problem or hypermobility. And that kind of lends for patients to have these other issues. We know that in hypermobility and EDS, there's a huge immune component. So there's autoimmune disease that occurs, there's immunodeficiency, there's mast cell activation syndrome. And, but then we also have a huge overlap with endometriosis and pelvic pain. And in my context, we know that endometrial tissue has mast cells at a higher number than regular uterine tissue. And so we've got overexpression of mast cells in the pelvis when you have endometriosis, and that can cause symptoms to also develop in that capacity. And then there's the issue of pelvic pain, which I see a lot in my POTS patients and often relates to pelvic venous congestion or obstruction of the pelvic veins that causes dilation of downward veins and pelvic vein varices that then causes pelvic pain symptoms along with orthostatic intox.
That's so helpful. And I know there's some really exciting developments in the treatments of POTS, dysautonomia, and compressed veins. Could you tell a little bit about how your office evaluates for this and what that would look like for a patient coming in?
Yeah, so this is a new area and a specific area of interest of mine, I think, because I see so much overlap between POTS and hypermobility and venous abnormalities. But, we often see patients who come in with pelvic pain and leg symptoms. You could have leg heaviness, back pain, lower back pain. Usually all these symptoms are worse when you're standing and better when you lie down. And we look at ultrasound in the office to see if the patient has a compressed left iliac vein or compressed left renal vein. Those are very common kind of anatomical compressions that we see. We also look at ultrasound of the lower extremities to look for venous insufficiency. So we find that either the veins are stretched or the valves in the veins don't work properly. And so blood's not getting transferred from the feet to the pelvis back to the heart appropriately. And so there's blood pooling that way as well. So we use ultrasound a lot in the office to look for these associated disorders. I mean, this is just one aspect of management of POP. We look for a lot of other stuff, and there could be other things going on, but that's one thing that we do look for in the office.
I feel like we're just learning so much, and this is such a wealth of knowledge to have all of you here. I meant to also say to our panelists, this is just a group of who's who. So if any of you want to chime in or ask each other questions that I am not asking, please do. I'm going to move to Dr. Chu to talk more about this pelvic component. You're an endometriosis excision specialist. Are there any shared mechanisms involving the connective tissue, inflammation, and immune dysfunction that you see with endo?
Tough question. And I think Dr. Cutchin's already touched on some of it that we're starting to recognize. So I always say, like, in a general sense, yes. And I think maybe we are seeing these same populations, obviously, in our different clinics, right? I think we, for the most part, all know that endometriosis, EDS are both recognized as chronic systemic, inflammatory conditions, and they have just really overlapping symptomatology. So that dysmenorrhea, that dyspareunia, heavy menstrual bleeding, chronic pelvic pain. It's sort of my understanding about EDS is there is a lot of chronic sort of oxidative stress. There's obviously that link between, EDS to MCAS and sort of this like inflammatory proliferative, myofibroblast, I will say, situation. From an endometriosis perspective, we know there's profound dysregulation of the immune system, both the innate immune system, the adaptive immune system. I think the innate immune system is studied a bit more, but, macrophages are dysfunctional, natural killer cells are dysfunctional. You have more B cells, things like this, and definitely that mast cell involvement. So Dr. Cutchins is absolutely right. There are increased mast cells within endometriotic lesions. And I always say, and I say this again a lot in my own clinic, that these are sort of self-perpetuating little microcosms, unfortunately, of sometimes pain, right? Pain and discomfort. So these lesions can, create their own estrogen, and that creates that self-perpetuating loop, and then estrogen then stimulates mast cells, right? So I think that is a very big link within our patient population. And there is also a degree of oxidative stress. So a lot of that in endometriosis is iron mediated from menstruation, but I think those are sort of those big links that I see.
Do you see any special surgical considerations for people with EDS or hypermobility?
Yeah, so I've thought about this as well. I don't know that anything is like specifically written for EDS patients, but just from a structural perspective, I think we're all thinking about things like tissue laxity. So this population is at slightly increased risk of things like prolapse, hernia. So even mentally, if there are situations where I will put one stitch, I may put two. If it's one layer, I may put another. That's from a personal, just myself. For a lot of my patients, I recommend pelvic floor therapy. I think it's essential. I think it's not optional for EDS patients. This is a big part of their care. Strength training. I may counsel them actually that their recovery process may be just a bit longer than their cohort. And then also just to think a little bit about their co-conditions. So things like, POTS and MCAS. So they are most likely the person to call me with a rash all over their belly button or an atopic reaction. They may need, they are the ones that definitely need that bone broth or electrolyte rich fluids, compression stockings, things like that. So
just having that perspective is so important, and that these patients are going to know you have seen this before, which gives them a lot of peace of mind.
Yes, that is helpful. They do ask me that. Have you ever seen this before? I do get that.
And I'm curious, I always love to know from a hope perspective, are there any exciting treatments or developments that are coming into the endo world that give you excitement?
Yeah, I mean, I think I'm definitely excited about things, and I think for everyone here, even if they're not fully realized, right? And I was actually a little bit harsh. ACOG, which is our governing board, just came out with a new practice bulletin, and I actually wasn't that excited about it, but because it did have some shortcomings. But I'd like to focus on the positive aspects of it here. And it really just said that you can now diagnose endometriosis clinically. It doesn't have to be on pathology. They made a big statement about that. There was sort of formal recognition. There has been sort of inadequate medical training in this condition, and that we need to do better. There is and I think there's also just like a race to diagnostics. So everybody is looking at different things, saliva, blood, et cetera, that you can use to diagnose endometriosis less invasively. There's a new test out called Endom. It's not available in New York, but I do know that other practitioners may be starting to use it. Again, it's not perfect. It's sort of a rule-in test, meaning if if it's positive, it has a very high positive predictive value. But if it's negative, it doesn't necessarily mean you don't have endometriosis. But again, I think that is still progress. And I think just the last thing I'll say is just the whole paradigm shift. Like we have stopped viewing this 100% as a hormonal condition, a surgical condition. This is now an immune-mediated condition, inflammatory condition that is really impacting, the therapies that we are considering for this medication. Really, we don't have a ton of medications for endometriosis, so anything within our arsenal would be great. So.
Thank you so much, Dr. Chu. I really appreciate that. We're going to shift over to Charlotte. We're going to chat about pelvic pain and vulvar pain. How does MCAS impact pelvic pain conditions like endometriosis and just vulvodynia, vestibulodynia, any type of vulvar pain?
I'll definitely speak to the vulvodynia aspect. So our understanding of how this trifecta leads to vulvar pain is definitely evolving. It's a focus of research in our practice. What we understand about MCAS is that one of the ways that it leads to vulvar pain is at the tissue level, where these mast cells are communicating with superficial nerve endings, and they're leading to a process called neuroproliferation. So there are new nerve endings growing, and specifically in a tissue called the vestibule, which is a ring of tissue that's between the external genitalia, which is the vulva, and the internal, which is the vaginal canal. The diagnosis is called neuroproliferative vestibulodynia. So Odine was the Greek goddess of pain. Vestibule means entrance. So this is pain at the entrance. Mast cells are our first line of defense against pathogens and allergens, and they're abundant in tissues that have exposure to this external environment, like the skin and the GI tract and the lungs, and mast cell associated disorders that occur in these areas are like eczema or asthma or GERD. And in the vulva, when the vulva is exposed to yeast or allergens, they can be activated and they stimulate this immune response and release of chemical signaling, which causes redness and pain and swelling and itch. And these are all familiar signs of infection or allergic response. But one of the chemical signals that they release is called nerve growth factor. It stimulates these new nerve endings to sprout within 1 to 3 millimeters of the surface of the skin. And when mast cells are chronically activated or overactive, it results in pain that persists after the infection is cleared or after the exposure to the allergen is gone. There's also a theory that you can be born with too many nerve endings, or that you may have been exposed to some mast cell trigger at an early age. And if that's the case, you may have pain with tampons or intercourse or speculum exams from forever. So it's never been pain-free. These nerve endings are specifically responsible for rawness, burning, and cutting sensations. So it can feel like a hot knife with light touch, but the skin itself generally looks normal. The most successful treatment we have is a vestibulectomy. And this is when we remove the tissue in the vestibule and we replace it with vaginal tissue, which is interestingly not susceptible to this process. And when we do send out these tissue to pathology, it shows increased nerve density and increased mast cells. So we know that this process is occurring. Research is really focused now on finding non-surgical options. Before we talk about research, I think that there are several pathways that can lead to vulvar pain that are related to the trifecta, and hypermobility and POTS. So we're looking for nerve and vessels and muscles that go to the vulva and cause pain. There's not one cause that applies to everyone. Not to make this more complicated, but more to emphasize the importance of having an exam, so that we can identify where the pain is coming from. Because sometimes we can ask all the right questions and know your history, but an exam is really important to make a good diagnosis. And I think that it's very important also to be treating the whole body, and that can improve your vulvar pain a significant amount. But if you still have continued vulvar pain, there's also mast cell treatments specific to the vulva that we can address with you. Part of our job is also helping you find the right people. So we're screening all of our new patients for hypermobility, MCAS, POTS, and endometriosis. And I like this panel. I hope it helps people understand who they need to see and prioritize where they need to go. I think that we are excited about collecting all of these information from on our question. All of our patients who fill out questionnaires see our patients who come to our practice fill out questionnaires, and we're gathering more data on how these are overlapping specifically for vulvar pain. And so more to come, hopefully soon.
That is so fascinating. I think you're right. Like this entire panel, I think I tried to have every discipline represented, because this multidisciplinary approach really is the key. And I'm curious, you're at the CVVD, there's some incredible research happening, as you mentioned, for folks that are maybe in New York, Washington, DC, Florida. They can come in and participate in these studies. Could you share a little bit about what they are and who might be a good fit?
Sure. So the two of the treatments that we're studying are for neuroproliferative vestibulodynia, which is what I was explaining. These ideas came from a meeting a couple of years ago called the Vulvodynia Therapeutics Research Summit. And it was a group of clinicians, basic research scientists, and representatives from advocacy groups that got together. And they all presented on different possible therapeutic options and then voted on which they thought would be most to least promising. So the number one selected was ketotifen, which is a mast cell stabilizer, and an antihistamine H1 blocker. We are enrolling for the first clinical trial that's measuring the effectiveness for acquired neuroproliferative vestibulodynia. So it's not someone who's had pain lifelong. It's a double-blinded placebo-controlled trial, so half will get placebo and half will get the treatment. You have to be 18 years or older, have at least 6 months of pain, and your pain has to be throughout the entire vestibule. We will assess that at your baseline visit, rule out other causes of pain that may exclude you, and ensure you're treated for hormonal causes or any acute infections before you're enrolled. And then it's 15 weeks long, and you're applying this cream twice a day, and you'll have 4 office visits, and we're still enrolling in New York, DC, and in Tampa. There's another treatment that's coming later this year that's a phase 1 trial. It was second ranked at that meeting for most promising, and it's called racinoferatoxin. It's a molecule that comes from a succulent plant called Racinophera. It binds to these nerve endings and ablates them, destroys them, and then theoretically normal nerve endings grow in their place, and then normal sensation will be permanent. Similar to capsaicin, which is a treatment we currently use. Capsaicin comes from chili peppers. It's what makes them hot. It's used for neuroproliferative vestibulodynia, but it's quite painful to apply. This racinoferatoxin is about 1,000 times more potent, and it's injected into the vestibule while you're under anesthesia. So it's too painful to be awake for it. Enrollment will be later in this year. It's 20 women. Visits are all done at the NIH, and this has never been tried before. It's phase 1 trial, so we're excited about that. The other trial we have ongoing is Botox for pelvic floor muscle dysfunctions, but this is only for pain for muscles, so not for neuroproliferation. So if you have pain throughout the entire vestibule, you wouldn't qualify. We also have several studies on lichen sclerosis. All of our trials are listed on our website, and there's an email to reach out to our research coordinators so they can talk to you about if you're eligible, any questions you have. So definitely check it out. It's on vulvodynia.com. Yeah.
Amazing. Thank you so much. It's exciting. Again, I'll try to pick out these moments of hope, right? I mean, I think with Dr. Cutchins, sharing about the compression and vein treatment, like that's a huge new avenue with Dr. Chu and the exciting, avenues coming with endo, new testing possibly, and these studies. I think often we're dealing with a lot of the emotional pieces that it feels very hopeless. But I hope that part of this is we're focused on a lot of things that are moving forward, and so much has changed in a relatively short amount of time. Dr. Alina Ivanina, I'm excited to shift over to you. Again, you are an incredible gastroenterologist with an expertise in MCAS and other conditions, but since we're talking about MCAS today, I'm curious, I feel like there's a lot of challenges in getting a diagnosis of mast cell activation syndrome, given fluctuating systems, maybe the criteria. I'm just curious kind of what you see in those challenges and how you address that with your patients.
Sure. It is definitely a difficult diagnosis to navigate. And I kind of think about focusing on two aspects. The lack of education to clinicians around MCAS. I don't know about any of the other clinicians here, but I was not taught about MCAS in my GI fellowship at all. And only afterwards, there's a very famous MCAS researcher in Belgium that's put out a lot of really fascinating information breaking down how MCAS really could be one of the drivers of IBS symptoms. And of course, we're always trying to figure out what is IBS, because IBS is just a list of symptoms, which doesn't tell us too much about what is causing dysfunction of that gut-brain axis, right? So I think, again, for us, that is a huge piece, is having these discussions and, having other clinicians hear the terms, like learn about this, because a lot of patients will come to, a physician with all their symptoms and they won't, again, the physician just never learned about this. So it is important to get the word out to both patients and clinicians, so so it becomes a more recognizable condition, because especially after COVID, it is increasing in incidence, right? We are seeing more MCAS. I think that, of course, like you were saying, as far as the actual diagnosis and how to make it, that also is very elusive. We know that our MCAS patients usually check every box in what their symptoms are and review of systems. But then when you go to their testing, their test results, they're all perfect, right? So this is that patient who feels awful, but their test results are perfect. And so there are multiple ways, again, especially like if patients advocate for themselves, there are now, guidelines, there are questionnaires like that are, really useful, that I think that patients can look at and also bring to their clinician so that they can help them understand what goes into diagnosing MCAS. And again, even the diagnostic criteria that we have is not ideal, because the mast cells produce over 200 mediators, and we measure a small handful of them in basically the few blood tests and the few urine tests that we do. And often the levels of these mediators that are excreted are going up and down based on how symptomatic you are. If you are at baseline, you may have normal results. If you are flaring, you also may have normal results, but there's, hopefully a higher chance that something will be elevated. So again, there are a lot of nuances to making the diagnosis of MCAS, but the thing to remember is, again, there's not really, a negative test with what we have to test for MCAS still does not rule out MCAS. So you have to keep going. You have to keep advocating for yourself as a patient, because it's such a tough diagnosis to make.
I think that's probably very affirming for people to hear, that just because they were told no, that doesn't mean they're crazy or that there's not something happening. One of the things about your approach that I love is that not only do you address the maybe more, Western medicine side of things, but you also bring in so much nutrition and a holistic approach. What both treatments and nutritional changes do you see that benefit maybe this overlap of clients with endometriosis and MCAS?
Sure, it's a great great to kind of talk about the many ways we can really approach MCAS. And I think, of course, we want to kind of start at the core, which is diet, because diet's important in pretty much every condition that there is. And so I think when you think about both endometriosis and MCAS, something that will help both patients is to explore a low histamine diet. Now, you have to be careful, because there is histamine in a lot of foods. And so you're always on the edge of not wanting to introduce a restrictive diet to the patient, which will then deplete their beneficial microbes, right? If you're taking away all the good foods, you want to really have a really great nutritionist and team on board to talk about what are the actual triggers within the histamine diet. And I would say that the one I'd really like to point out in diet is going to be red meat. So red meat has been shown to be something that has been associated with increased risk of endometriosis, as well as high in histamine. And that's because it has the amino acid histidine in it, that with the process of storing, preparing, cooking, keeping it, in the fridge, more and more histamine is created. And so we have this, again, phenomenon with the low histamine diet, that it's not even just a particular food, it's actually the fact that it's also going to be building in leftovers. And again, especially in ones like red meat. So, I think, although we live in this protein craze right now of everyone wanting to optimize their protein, but I think that one thing really important with patients who do have both endometriosis and MCAS is to see how they feel, how it affects their pain, if they really do limit red meat. So I think that's a big part of diet. And I think the other part is trialing a DAO enzyme. And this is not something that has a lot of research around it, but it can help break down histamine in food. So again, this is a thought that is in general very well tolerated. So it helps a lot of people. So they, again, don't have to be so restricted. They can go out, have a life, be social, because that's really what we want our patients to be able to actually enjoy life while they, figure out their health and on their healing journey. So I'd say that the next step we think about are natural supplements and treatments. And one that I find has been helpful to patients that I have who have both endo and mast cells is quercetin. So quercetin is a polyphenol blend. So basically it's a polyphenol is like a very anti-inflammatory plant substance that we're learning more and more about. It's kind of the reason behind the saying, eat the rainbow, right? Everyone's always like, well, why? What does that mean, right? It's because plants of different colors have different polyphenols. And so the more, variety you have, the more you'll be exposed and the bigger the antioxidant and anti-inflammatory benefit of all those substances. So quercetin is, again, something that's really nicely well studied. It's in our, we don't necessarily have a guideline in the GI world, but we have some of the big specialists who've written, on some of their top recommendations, and quercetin is mentioned in those. I would say, next, when it comes to treatments and medications, I don't know who here has heard of the internet, the craze that broke the internet about taking Pepcid and Zyrtec for everything, right? So Zyrtec is an H1 blocker and Pepcid is an H2 blocker. And so together, and again, a lot of times you stack the treatment. So you'll start with something like quercetin and the diet, and then you can add on the H1 and the H2 blockers. And in general, again, these are over the counter. These are very safe medications to trial. And so again, I think the internet has broken down with all these people who have tried it, who have had issues, for example, like cyclical pain, right? So when that estrogen is spiking and it is causing histamine to increase, then people are having more pain because histamine, we like to say histamine hurts. Histamine is a painful substance. And so all of these patients who have experienced more, whether it's like PMDD or other types of cyclical pain, they've all started reporting that they're feeling so much better on this treatment. And so we see this a lot in patients, and that just, again, this simple treatment, which is very well tolerated, can tell you a lot about the origin of the pain. And that is part of the way we also actually diagnose MCAS, right? So because it's so difficult to diagnose MCAS, we also talk about, well, what do your symptoms respond to? So again, that's a really nice base for MCAS and, also endo with, again, the variations in estrogen. And we know the connection, as everyone discussed, is really strong there. And I'm going to bring up one really interesting new treatment, which is increasing in, I think, our awareness and the literature, and that's going to be the GLP-1 agonist group. And so that's, again, there's not a lot of evidence around this. This is very up and coming, but we know that there are GLP receptors on mast cells, and there's emerging evidence with case series that have been published that really show that it's anti-inflammatory for patients with mast cell. And I even this morning had a patient post endometrial resection and excision. She was started on a GLP-1 also, she was experiencing a lot of swelling and a lot of other treatments. And, again, I think it's very, very much in its youth, this treatment for these conditions, but to talk to your provider about whether or not, that can, again, be something that would help both conditions, which is something we all want to do, is decrease the burden, the pill burden, right, of the medications these patients take.
I love that you're including these exciting new treatments that are giving hope. I don't mean to put anyone on the spot, but especially Dr. Cutchins, Dr. Chu, are you noticing, even though I know this is emerging and not necessarily research-based, there's not the research yet, but we're seeing this anecdotally of the GLP-1, either microdosing or anything helping what you're seeing with your patients?
Yeah, I use a ton of them. I think they're doing great things for patients, especially people who have a lot of medication intolerances. That can really help because they're not taking it orally. It's injected. And so I usually start patients in very, very low doses, like a tenth of what the normal starting dose is, and gradually increase it. But I'm seeing I had one patient today who told me he instantly had this fatigue lift when he started taking it. So, it's daily I'm hearing good stories. So I think it's pretty safe that they're FDA approved. And, I think with the right directions and the right acknowledgments of potential side effects and, what we can see with them, I think that they're a great new tool.
I want to jump in. I agree with Dr. Cutchins. I utilize like 1/10 the dose of these GLP-1 GIP medications. And I know it's anecdotal at this point, and they really are so helpful. And Dr. Chu, I'd love to hear what you have to say about GLP-1s.
I think I was in something a while back, and we were talking that a lot of what we do is emerging medicine, right? And so there may not be the studies and a lot of sort of what we see in our clinics that is a lot of great anecdotal evidence. And we have obviously seen a lot of this throughout the clinic. So yes, I'm seeing the exact same thing. And whether they're on it for actual indications or they just decided they wanted to try it, I'm noticing more with, just low dose tirzepatide. I think that's sort of been, just like the sort of the Pepcid and the Zyrtec craze, that's the craze that's coming through. And again, really, really low dosages. I obviously tell them, hey, remember to pair it with that strength training, et cetera, all of the things that we are telling our patients. And I think, Dr. Ivanina, people really tell me the endo bloat, the endo belly is one of the biggest symptoms that they feel relief from. So.
Yeah, makes sense. And I was just going to put in a little plug that a lot of people talk about the GI side effects of GLP ones, which are real, right? We know that early on, it's the stomach slowing, that is part of why it works. But when you take these microdoses that Dr. Cutchins described, it is very rare to have GI symptoms in my experience. And so a lot of patients that I see are like, well, I'm already constipated. I can't even consider this. And I'm like, that's not true, right? So again, in these tiny doses, I don't want people to feel that just because they have GI symptoms, it's going to suddenly worsen everything. In the small microdoses, I think patients do really well when you start low, go slow, monitor them carefully. These GI symptoms won't kind of come out of nowhere. You'll see them slowly, and then you can scale back.
Also, I want to piggyback too from me and Kara. Kara would agree with me too. I think the patients just in general have less pain and complaints of pain with the microdosing, and definitely aren't complaining as much of GI side effects. But the pain aspect, I feel like, it's made a huge difference for endo patients, at least.
This is so exciting. We're seeing this now. I want to point out the specialties, right? Cardiology, gastroenterology, endo-excision, physical therapy, that all of these multidisciplinary approaches, everyone is seeing these differences, which is really exciting. We're going to make a left turn to go into psychiatry and mental health for a moment. Dr. Brandon, I'm so excited to have you on because you are a gut-brain axis expert. I'm curious how you see conditions like MCAS impact mental health, and does this ever impact the correct diagnoses of mental health conditions?
Yeah, definitely. Well, one thing I do want to say though, Kelsey, is it's not a left turn because mental health and physical health cannot be separated from each other. So they really are just like on the same parallel pathway. If you're not treating mental health, it would be really difficult to treat your physical health to completion. And with that in mind, right, MCAS and psychiatric conditions, they have this neurobiological overlap to them. So I end up seeing tons of patients. They've seen, a lot of different doctors. They've experienced maybe even problematic medications that they've been given. Like doctors really want to help people. And so sometimes they get lots of drugs that don't end up helping them and even could be ending up harming them. I do want to say just a quick plug that anything I'm talking about is educational only, not medical recommendations or advice for any patients, because I'm reading the chat and I know people are sharing their own personal advice, but this is just educational information, of course. But when we think about, when I think about a patient that's coming to me that maybe has failed lots of different medications in the psychiatric world, maybe a lot of doctors have said, like, you know, I think at this point, this is probably more of an anxiety diagnosis for you, or even a brain gut axis diagnosis that is just not responding to what we would think of as like traditional treatments. Sometimes it starts to ring bells in my mind of what are we missing? You know, we always have to step back and be humble about what is the diagnosis that we're actually treating in this case. And one of the major things that, well, there's two ways I think about this. There's probably an underdiagnosis of MCAS. You know, there's a lot of psychiatric symptoms that can look that MCAS can make you look like. So there are reports of anxiety, depression, bipolar disorder. People are misdiagnosed with these psychiatric conditions. And in fact, there is such a huge overlap that like they might actually have MCAS, or they also have MCAS, right? Those things don't have to be mutually exclusive. But it's worth making sure that we're ruling that out or ruling that in. And as the other panelists were saying, it is difficult sometimes to fully rule that in or out. So trying things and being thoughtful about the patient's symptoms and seeing if other things could be helpful or other testing could be helpful is important. But there's a Dr. Ivanino was saying, you know, there's this huge explosion on the internet of everybody saying, just take Pepcid and Zyrtec and you're good. There's also like an overdiagnosis, I think, of MCAS to some degree. There was a study that was, you know, 2% of 100 patients, so 2 out of 100 basically, that were suspected having MCAS actually had it. And then 65% of those patients also had anxiety or depression symptoms. So most people don't want to hear about psychiatry when they're suffering physically so badly. And I just, you know, again, want to plug that these are not separate things. You can have MCAS and be impacted psychiatrically with that. And you can also have psychiatric symptoms, and those are worsened by MCAS as well. One of the main drivers for that is actually a tryptophan dysregulation. And the corticotropin releasing hormone dysregulation in our body, where if we're stressed, whether it's a physical stressor or a psychological stressor, cortisol is being activated, and that's impacting the entirety of our body. Like our whole immune system gets sort of set on fire, and mast cells are, of course, a part of that. So it's impossible to separate them out. And it's also really important to make sure that we're treating both of those things and getting the doctor, like all the doctors talking to each other, right? Like that's why this kind of a panel is so important, so that nobody's in a silo of saying you either do or don't have mast cell activation. The doctors talking to each other is one of the things that I find most important and most empowering for patients, to have a better sense of getting the correct diagnosis and feeling heard when they're working through this, and not being told like it's only in your head, or there's no chance that it's also anxiety that's worsening things for you.
I love that. Yes, you. I'm echoing, so I'm going to mute for a second. I love that you echoed that two things can be true. There can be mast cell, and it's valid, and it's not taking away that these conditions can exacerbate anxiety and depression. But I love your holistic view on that. And you're right, it wasn't a left turn. You corrected me on that. I love that. Is there new research or approaches that help you feel hopeful for just any kind of these complex mental health, you know, and chronic conditions?
Yeah. Well, I think psychiatry is moving more towards like getting more integrated into the immune world and trying to sort out if there is any kind of immune dysfunction that is provoking or worsening psychiatric symptoms. So there is more work in like in the psychiatry world thinking about anti-TNF alpha agents like infliximab, adalimumab for patients who have high markers of inflammation in their body to see if those things are able to downregulate depression and anxiety as targeted mechanisms. People are already mentioning the GLP-1s, of course, like in the MCAS world, that can be helpful. And if the GLP-1s are reducing anxiety in a lot of patients. And so is there an overlap? Is that treating anxiety? Does it matter? I mean, it's like hard to like totally tell what is it doing and what the future potential is for that. There's also, if a patient comes to me and they have already been talking with a doctor about having higher histamine levels or mast cell activation, it's important to think about research that we can see happening in psychiatry about which agents to be picking for those patients. So some of the older drugs in the psychiatric world, like the TCAs, specifically doxepin and amitriptyline, those are a little bit more potent H1 antagonists. So they could be helpful in mast cell syndrome, and mast cell activation syndrome. And then we continue to see a wealth of information about cognitive behavioral therapy. And I know Ariel's probably going to chat a little bit about this, but there are trial after trial talking about how mindfulness interventions, cognitive behavioral therapy can significantly reduce depression and anxiety, and provide an outlet for people who probably have been chewed up and spit out of the medical system with all these sort of vague syndromes that are going on. And to see that as like just as impactful in like inflammatory conditions like inflammatory bowel disease, rheumatic disorders, MCAS, where stress can be one of the triggers that is causing that mast cell degranulation. It's just really important to make sure that we're, again, targeting all those pieces. But I feel very hopeful. It's more and more being talked about as like, not just talk to somebody and you'll feel better, but that there is true clinical outcome data to show that reducing these cortisol, tripwires basically is incredibly helpful in patients in the psychiatric world.
And I want to point out too that you are a consult liaison background psychiatrist, which for patients who might not know if they're looking for a psychiatrist, your training specifically helps you work with a medical team on complex cases. So is that something you recommend patients looking for?
We keep competing with each other to mute and unmute each other. Sorry. So yes, I think having that background, consultation is seeing the patient, liaison is working with the medical team. And so my specialization is in exactly what you're saying. The tricky part is that consultation liaison psychiatrists tend not to exist very much outside of a major academic hospital system. And like lots of medical doctors actually don't know what is a consultation liaison psychiatrist, because most specialties is like the consult gastroenterology team or the consult cardiologist, and like consult liaison is overcomplicating it, which makes sense because we're psychiatrists. But it's, the reality is that yes, it would be amazing if you could find somebody that was medically integratively informed like that, and they are hard to find. But if you can find somebody that at least is sitting with you and thinking about this and not just saying like, take this antidepressant medication and like, it's, they're not like looking at any further investigation or understanding more about where you come to the table with the psychiatric symptoms, then, it doesn't really matter if they're consult or not.
I think just having that understanding is so helpful. Also just a new maybe lens that patients can have when they're looking for someone. And they might be nervous about trying a psychiatrist, but that kind of background can be so helpful. And I do want to echo what Dr. Brandon said. I should have said this up top, but yes, everything here is educational purposes only. Everyone here is donating their time for EDS Awareness Month to share things, research, exciting possibilities that they are noticing, and to emphasize this needed multidisciplinary care approach. And I love that the chat is going. As you're putting in your Q&A, just know we will not be answering individual medical questions, but I'll be looking through this in a little bit as we do a little Q&A at the end. And I'm going to now shift to my teammate, Ariel Katz. You are a specialized therapist for women with chronic illness. Dr. Branham mentioned CBT, but what kind of other therapeutic tools do you like to utilize when working with these clients with complex conditions like endo and EDS?
Yeah, so I utilize a lot of third wave cognitive behavioral therapy for endo and EDS because it really allows us to kind of change the relationship to those painful thoughts, feelings, and sensations that show up with endo and EDS, and of course, the lived experiences and trauma. And what's so special about these tools is it really actually allows us to make space for painful experiences. So in turn, we're able to live a meaningful life alongside pain while reducing suffering and increasing acceptance and resilience and also feelings of safety. So I pull a lot from acceptance and commitment therapy, dialectical behavior therapy, and trauma-focused cognitive behavioral therapy because there are just so many rich tools that we can use here. And with each individual that I'm working with, I really make sure that when we're forming a coping skills menu, it is so personalized based on what each person needs. And then we also have different coping skills across different levels of distress and different types of distress. Something that is really helpful to incorporate is nervous system downregulation tools. With endo and with EDS, it's unfortunately very common that people have experienced some form of medical trauma or invalidation, dismissal, gaslighting, and this, along with the symptoms, naturally will impact the nervous system. The nervous system can often be in a state of being upregulated, and we can experience really challenging and really intense emotions. And when this happens, we can actually utilize tools that helps to bring the nervous system into a safer space. And the purpose of this is not necessarily to say that the pain is invalid or to take away the pain, but we can experience our emotions while also feeling grounded and safe. And these tools are really person specific, and I'm going to list some examples here, but I also want to clarify that, make sure if you are using any of these tools, you're working with a professional and making sure they're safe based on your background. So we can use some bilateral tapping, some grounding, breathing. We can utilize gentle stretching if that's safe, or exercise. Sometimes we can use creative skills, accessing temperature change. The list really goes on, and again, is something that is so person specific. I'll also incorporate a lot of mindfulness tools as well. When we experience pain, our first instinct, and it's so automatic, is to kind of push away that pain or judge the pain or maybe ruminate around painful thoughts. And the mindfulness is just another way to downregulate and create space for this pain by looking at the pain and the present experience without any sort of judgment. And this can help to increase feelings of acceptance, unhook from painful thoughts, or even reduce fear. And with mindfulness exercises, we go into it without any sort of specific goal, but there is a great side effect that we can feel more relaxed when we use mindfulness. And a great place to kind of start with mindfulness is something like a leaves on a stream or clouds in the sky, mindfulness visualization, where we may take painful thoughts and put them on leaves and allow them to float by on the stream or clouds in the sky. And we just allow it to go by at whatever pace the thought wants to go by, in order just to create some distance and some space and start to change the relationship with the pain. We'll also utilize, like Claire was saying, some more traditional trauma-informed cognitive behavioral therapy, where we may integrate some reframes, but we also want to acknowledge how our unhelpful thoughts or our stuck points may have served a protective purpose at first, and the ways in which they may not be serving us anymore. We can also incorporate some dialectical thinking as a great tool, and this is something where we allow two realities to coexist at the same time. So something along the lines of, I am in pain and I am doing what I can to protect myself or to support myself right now. This helps to validate what we're going through while also broadening the picture, create acceptance, and also can help with reducing suffering. Another great tool that I love to use is self-compassion. And I know self-compassion does not come easily, especially dealing with endo and EDS and the very specific kind of medical traumas that come along with it. When we've experienced that invalidation or dismissal or gaslighting or minimization in medical spaces, a lot of times we may end up experiencing strong feelings of shame, like I'm not deserving of care, I'm not good enough, I'm a burden, because it can actually feel safer to turn inwards. And it serves this really strong protective purpose at first. But over time, we learn different ways in which we can protect ourselves, and we start to recognize that shame may be actually contributing to some suffering. So a great tool to start is actually some mindfulness around the shame, thanking it for trying to protect us, but recognizing there may be other ways in which we could protect ourselves. And I love the simple question of what would you say to a friend, or what would you say to someone else going through this? And how can you apply this to yourself? Also, I use a lot of just kind of practical tools. Communication skills are a really big one. Definitely boundary setting can be a big one as well. Just understanding what's needed to navigate different pain flares. Some decisional balancing can be really helpful. And also just like more organizational skills as well. When we're navigating so many doctor's appointments and living life in general, it can be really hard to just find that balance. So having those balancing skills plus organization skills can just really be helpful with navigating life with chronic illness.
I love that you're also offering a toolbox, right? So folks can kind of pick and choose what skills are working for them. I'm curious, for you, we talk a lot about multidisciplinary care. This is why we're doing this kind of panel, because it takes a team. What does multidisciplinary care mean and look like for you?
So multidisciplinary care basically means that different providers with different specialties will be communicating with each other and working together in order to help the client best reach the client's identified goals. So with the multidisciplinary care, the client is sitting in the driver's seat, the client is deciding the direction they want their care to go, and then the different providers will communicate with each other in order to make sure that we're aligned with creating a treatment plan that focuses in on the entire person. As we've touched on before, we can't just siphon things into physical health or mental health. We really want to work together to take on that holistic, integrated, and of course, trauma-informed care. This can more specifically look like, I'll give an example of a physical therapist working with a client and noticing that the medical trauma is really impacting the client. So they refer them over to mental health counseling. And then after meeting with the client, we all decided it would be great for the providers to be communicating with each other. So we talk about the mental health goals and the physical health goals. And a lot of times these conversations are very much focused on the client's strengths so that we can be utilizing that to best inform care for the client. We then figure out ways in which, as clinicians, we can also be supporting each other to provide that best care to the client. With physical therapy, sometimes what I'm finding is that we will work together to stack the mental health exercises, like that nervous system downregulation, with the physical therapy exercises. Or I may notice a client would really benefit from breathing exercises, but it's out of my expertise to know the proper way for this specific client to be using a breathing exercise. So I can then communicate with PT so we can work together on how to safely integrate the breathing exercise there. And there are so many different permutations on how this multidisciplinary care can look, but it is really just such a great way of allowing the clients to really feel safe and seen and heard from all different angles when they are receiving care.
Well, it really helps cut down on the client mental load. And also we're trying to stack these things so we're not overwhelming with exercises or different tools. And we'll go into our pelvic and ortho physical therapy and hormone section to end this amazing panel. Erica, you are an expert pelvic floor PT. What pelvic floor findings are you noticing with your hypermobile or EDS patients?
So I was just thinking about this question, Kelsey, because in physical therapy school, Kara and I learned how to treat EDS from however many years ago, but only the past 5 to 7 years, I would say, has it been even correlated with endo and EDS and POTS. It's just so interesting to me. So we always treat it as a separate thing, and now it's kind of all encompassing as we're seeing it, all 3 things or 4 things in one patient. But with the EDS patients, just as in a physical therapy setting, when they're coming in to see us and we're assessing them, the first thing you notice with these patients is that when they're standing, their hips come forward and they have this anterior pelvic tilt. You could spot these patients from a mile away, right? They have their knees are hyperextended, and so you see that with the patient just standing right in the room. And then when we're assessing them and we're looking at them externally, you'll notice a lot of core weakness, and you'll see that the patient's popping out or doming, or their stomach's coming out more, having them engage their core. A lot of these patients are more prone to hernias. So you'll see an abdominal hernia or inguinal hernia in these patients. And then when you're looking at their hips are hypermobile, obviously, and you'll see SI joint pain. So just externally tailbone pain because their joints are more lax. So those are just the things you'll see right away, right? And then when you're looking at them internally, or you're doing an internal assessment, you may see sensitivity along the vestibule, what Charlotte was saying, and with vulvodynia and vestibulodynia. And we see a lot of mostly hypertonic pelvic floor in these patients. So they're not lax, or you're not seeing hypermobility. I'm seeing more hypomobility in the muscle with trigger points, because when you're looking at an EDS patient, the muscles internally are going to tighten to stabilize their trunk, right? And to stabilize the laxity in their hips. So there's a hip muscle internally, and then they have their pelvic floor muscles internally, and those muscles are holding on for dear life to give the trunk stability, because the core can't and their hips can't. So we see that with the patient, and you'll see pain with intercourse. We will also see, and I know Kara's going to touch on this, with assessment and exam, that more ligament laxity in their organs. So their bladder may come down a little bit, their urethra will come down a little bit more when we're having them bear down, and then rectally, you will see more of a rectocele in those patients when we're testing them, but also hypermobility of their anus or external anal sphincter and the pelvic floor muscles around their anus. So that's just in general what we're seeing with the EDS patients on exam.
I think this is such helpful information, not just for providers but patients too, but also I know we have providers joining us that might be putting these connections and dots together. So thank you for explaining all of that. It's just a wealth of knowledge.
Just even to say their complaints in subjective, when we're seeing them on the exam, would be for bowels, I'm constipated, or I'm not constipated, but I can't fully empty my bowels. They're still stool stuck. That's all part of this EDS pathway or whatever. And then we're seeing a lot of incontinence, or they're having bladder urgency frequency because their pelvic floor is hypomobile, so it's on the tighter end. Pain with sex, and endo symptoms. So all of that. MCAS, obviously, and POTS.
One thing that you and your team do so well is setting expectations for folks with endo and as they're preparing for surgery. How can patients prepare for a successful surgery and these expectation settings?
So when the patient comes in before surgery, we really talk a lot to them about what to expect after and prepping themselves up to surgery. So we could give them a handout or whatever about like what to get before surgery, but we want to make sure like pre-surgery that the patients are not experiencing constipation or straining on the toilet, because when you're with post-excision surgery, the last thing you want to be doing is straining or having bowel discomfort. That's like one of the number one things, right? Getting them squatty potties. They may need a sitz bath when it's safe to do that post-surgery. So bowel management is super, super important. We talk about they might get shoulder pain from gas. So we're talking about things to alleviate that, whether it's a supplement, some exercise, moving around, things like that. We're talking to them about, well, we're working on the pelvic floor. So a lot of pain, secondary pain to endo is pelvic floor tightness and pelvic floor dysfunction. So we're working on their pelvic floor before surgery so that post-surgery they have less pain, right? They might be getting injections, trigger point injections, Botox before, but we also talk about it post. So they may not be getting that before, and then they're getting their endo surgery, and then they might be getting trigger point or Botox injections later. But to really prep them post-surgery, and I know Dr. Chu's office gives out like a little baggie of like all of their supplements and Colace and whatever else, slippers, socks, whatever. So we try to like go through, and Kara did like a reveal on our TikTok. It was funny about like all the little things post-surgery. But so we go through all of that with the patients. But a lot of the expectation is sorry, my son is walking in the room. Please go in the other room. Post-surgery, what we really talk about is when are they going back to work? A lot of patients are asking that. When are they going back to work? And some patients are, when can I try to have a baby too? So that's like the physician question. But so what we're doing, we're telling them like if you have a remote work job, 2 weeks, you could probably start doing the job remotely. If they have a physical job or they're going to the office, we always say 3 to 4 weeks going back to work. But also it is dependent on their physician too, and what the surgeon. Some patients come into PT 2 weeks post, and depending on the surgeon, and some come in 4 weeks after. So I feel like I'm digressing, but yes.
And that's so helpful. I know you've also shared, just to help normalize, you might feel not quite even healed, or I'm not using the right terminology, but you might feel a little off even up to a year of this healing post-surgery. Is that a good expectation?
So we say for 6 months, your periods are still definitely going to be painful. If they may not be, but if they are, don't stress. Because that is definitely normal if there's not a hysterectomy involved, obviously. But I always say, and Kara can attest this too, at least a year before you really feel a lot of symptoms go away. And then I always say to them, sometimes you really feel bowel symptoms relieve first. That's like one of the first things. So that's definitely an expectation we set for the patients.
It's so helpful, especially from a mental standpoint, to kind of know.
Because they're always asking right after, and it's super helpful that they know that before.
And this is where that multidisciplinary approach is, that we in session can help decatastrophize, knowing that that's part of this evidence, right? That it could be 6 months to a year that certain things are still coming up for you. Thank you so much.
Oh, and also another thing, just to note for the people listening, if you're having a lot of like abdominal soreness, we always tell patients you did too much that day. So you have to really like progress slowly.
That's so helpful.
And monitor your own symptoms. Yeah.
And Kara, you didn't get to introduce yourself, so I will help intro you. That you are the co-founder of Solstice and Erica's teammate. I'm so happy that you're here, and thank you for co-hosting with us. You are another expert pelvic floor PT. How do you see hypermobility or EDS impacting pelvic organ prolapse?
working before. So in folks with EDS, they're going to have a twofold increase in pelvic organ prolapse as compared to the general population. And so with that, we know that our pelvic organs, our bladder, our rectum, uterus are supported by connective tissue, which is made of collagen. And so in these folks, the collagen is not strong enough and it's not supporting things. So, like I said, they can have prolapse of any of those organs. And with that, they can have the symptoms Erica talked about. They can have stress incontinence, urge incontinence. They can have incomplete bowel emptying. They can have constipation. They can have diarrhea. So they can present with like a range of symptoms. And specifically in people that have EDS, like these symptoms are more impactful when they're under the age of 40. Like if we have a patient that comes in and is 25 and has a rectal prolapse, we have to ask the question of why, right? Versus like if somebody is postpartum and has a uterine prolapse or somebody is menopausal, it makes a little bit more sense. Versus somebody younger having a prolapse, it raises, flags and questions of what's going on.
That's really an amazing distinction, right? Of that age can give you so much information to start asking different questions. And I'm seeing this a lot in the chat. So this is kind of a Q&A, but also part of our question. I'm curious, when you're looking for these experts or you're trying to find people that have this expertise, what should patients be looking for? Are there qualifications or trainings or directories that qualified pelvic or ortho PTs are a part of?
I don't know if there's an EDS Society of Physical Therapists. There should be. But I know for pelvic floor, there's the American Physical Therapy Association has a women's health section. There's also Pelvic Guru has a list of providers, as well as Herman and Wallace has a list of providers. And the reason a pelvic floor PT is better suited, I think, to help folks with EDS is because so many of these patients have all those pelvic floor symptoms. So they're able to treat that with manual techniques, biofeedback, use of the rectal balloon, but then they can also really work on like slowly graded exercise with the appropriate intensity and weights versus like your average PT may progress the patient too fast and then they could get injured, they could dislocate things. So, I really think a good pelvic floor PT with an understanding of the pathophysiology would be the way to go. And maybe we need a list for the EDS Society of PTs. We can work on that.
Yes. I'm going to put you on the spot a little bit, Erica. You mentioned subluxations. Could you define what that is for patients or providers? Because I think sometimes that word gets tossed around and we don't quite understand what we're talking about or what we mean.
Subluxation.
Or care. I'm sorry.
Okay, no, it's okay.
I'm sorry. I think I said Erica.
So subluxation would be dislocating, right? So if somebody's dislocating their shoulder, like it's coming out of the joint, or they're dislocating their elbow or their wrist, usually that would be a symptom of the EDS because they don't have the structural integrity. These patients know that they constantly can like pop their shoulder out.
That's really helpful to know. And as you said, the pelvic specialty, you have everything of the ortho background, but this is extra training, extra expertise. So you're coming in with that, even more narrowed down niche lens that you can look for all of these things.
Yes.
And I also apologize to our panelists. We're going a little over time. If anyone needs to hop off, I completely understand. We've got this, but we'll try to wrap up by 8:30. And then our final, last but not least, incredible panelist, Kathy Cates. I've had the pleasure of knowing you. And, hormones are having their moment with the perimenopause, menopause, but they also impact, the EDS endo population. Could you are an expert nurse practitioner. Could you talk a bit about the health of the vulvar and vestibular tissue, specifically how that affects pelvic floor tension in patients with EDS and endo?
Absolutely. So this is this area for everybody. This is this area that we're talking about in between your labia minora that's called your vulvar vestibule. And this tissue is dependent on both estrogen and androgens. And by that, I mean testosterone. And so when Charlotte was talking about the work that she does, and she's talking about when all of this tissue, so as a clinician, we palpate the tissue or we use a Q-tip, we call it the Q-tip test. And when someone is sensitive throughout the entire vestibule, That's what Charlotte means by neuroproliferative vestibulodynia, pain in the vestibule. And so think about this whole vestibule is inflamed. That's going to create a lot of pelvic floor tension. So for our patients with EDS, we already know, as Kara and Erica said, like they're holding. That's the only place these patients can hold is in the pelvic floor. So now you've got an inflamed vestibule that's exacerbating the pelvic floor tension. And then when we think about the hormone piece, for those patients, when you palpate, you're going to find exquisite tenderness really between, we use the pelvic clock analogy. So up by the clitoris is 12, down by the bottom of the vaginal opening is 6. And so really between 5 and 7 o'clock, you're going to find exquisite, exquisite tenderness. This is so much of superficial dyspareunia or entry pain. You'll literally see micro tears in the tissue sometimes. And so this is where the role of local hormone therapy can be so helpful. So what that will present on exam, these patients, and I know Kara and Erica will know this tissue is dry. It's raw. It even has, like I said, these micro tears in it. And that is where the role of local estrogen and testosterone therapy can be a complete game changer. And in my clinical experience, topical estrogen, it's amazing. It's having its moment. I love that. It's not enough. It's not going to appropriately address that tissue. And then when we're talking about endo, and some of endo, we want to try to suppress ovulation, right? So because ovulation can make things worse. And it's much more nuanced than this, but when we suppress ovulation, and it's not for every single patient, but sometimes we lower the circulating free testosterone, and it has a very powerful impact on this tissue. So again, not all birth control, not every single patient. It's much more nuanced than that, but you really have to assess that vulvar vestibular tissue.
And you mentioned systemic testosterone. What role does systemic testosterone play specifically in the EDS patient population? And how does low testosterone impact maybe what you're seeing in the treatment room?
Absolutely. So this is local, right? Like we talked about local testosterone, meaning vulvovaginally. And so what we see systemically is that, women, we have 4 times the amount of testosterone than estrogen, but yet it's so gendered that nobody ever thinks about it for women. Mm-hmm. So I want to invite us all. This is an opportunity to really think about how helpful testosterone can be, because testosterone is essential for collagen synthesis, fascia integrity, and lean muscle mass. And in EDS, ligaments are lax, so they can't hold the joints. So what you'll see like in your PT sessions is like, it just doesn't hold. Like you think you've gotten your patient to a certain point as a PT, and then like you just don't see the progress anymore, right? So when we think about from a mast cell activation perspective, human mast cells contain androgen receptors. And when they're engaged, testosterone can inhibit mast cell degranulation and calm the inflammation. So when people have low testosterone, it almost acts as a trigger for the mast cells. So, it's something that I think we're just not thinking about enough. And when we think about autonomic function, dysautonomia POTS, right? Testosterone contributes to healthy circulation, blood pressure regulation, and overall energy. And so if we optimize the testosterone, we might very well help in partnership with many of the people on this call to improve orthostatic tolerance. And then it's also going to help when we think about pain modulation and we think about the longitudinal data that we have on these hypermobility and EDS, the hypermobility spectrum. Hormonal drops correlate with increased pain sensitivity. And then exciting when we think about, I'm going to go back to the local application. when you look at this big data set, the NHANES, the big, huge data set, they found lower testosterone levels have significantly higher odds of overactive bladder. The tissue of the bladder and this vestibule are hormone dependent, right? And so that's where that local tissue health, like it really optimizing the local hormonal tissue health can be so important. I'm not saying it's for everyone. I just think we're completely ignoring it. And it's a tool we have in our toolbox that pairs so beautifully with everything that all of us on this call do.
You know, I think also everything, you wrapped this up into a beautiful bow of we can't silo these things. And I want to also honor, we've already gone over, but we're going to do one question that I saw. And I think I love anyone to hop in for this, but they were talking about the pelvic overlap spectrum framework that has, I saw it a little bit ago that Dr. Padali had written a little bit about, but, and I'm just looking at my phone, it's talking about all of these things: endo, reproductive outcomes, autonomic dysfunction, vascular disorders, immune reactivity, connective tissue, immune dysfunction, bladder hyperactivity, as you were saying, Kathy, and intestinal motility issues. Is this maybe the future as we talk about not the trifecta, but the septecta, whatever that would be? And if anyone has any thoughts, I'd love to close on this.
I can chime in here. I can chime in if no one else wants to. I just think that, yeah, it's not just the pelvis and the, pelvic floor and everything that's going on there with pain and endometriosis and everything else, but it's a much bigger picture. And so I think we all have to recognize that and, do our best to serve these patients on for all realms. And it's great that you have, a conference like this or a webinar like this so that people can understand, the overlap is really there. So I think Dr. Vidali's right. Obviously, there's all this other stuff going on in the pelvis, but it's much more than that.
Just to piggyback on Dr. Cutchins, like I think asking the right questions and making sure that your provider is asking you, like if you're coming in with one symptom, asking them about, are you getting lightheaded during this? Are you getting, are you feeling like you can't control like this, and this? And then making sure that that provider is recommending other people for you to see too. I know if sometimes that if the audience here, like if you don't know where to go, sometimes the PTs locally just know like all the doctors that are treating this. So sometimes they're just a good resource. Like go in for an eval, and like if you live in, New Jersey or whatever, someone local, and say like, who do you send to if you're experiencing these symptoms? Sometimes they just know too. So that's like a good resource to start with, even if, whatever, just
Absolutely. That's been such a theme in the chat of how do you find the right people? And I think if you find one person who's niche in this, we all have this incredible network of multidisciplinary providers. So again, I apologize for going a little bit over, but I cannot thank you enough, each of you. I'm honored that you are people that I know and can refer to and trust. And thank you from the bottom of my heart for donating your time for EDS Awareness Month, for sharing this educational information. If anyone maybe didn't get their information and you want more, you want to get connected with these doctors, please email me, Kelsey at Women's CBT. I'm happy to give the referrals. And thank you all again so much for your time. Very grateful for all of you. And I hope you have a wonderful evening.